Good morning. My name is Maxine Tran. I'm a consultant kidney surgeon at the Specialist Centre for Kidney Cancer at the Royal Free Hospital in London, in the United Kingdom. I'd like to thank the programme committee for this invitation to be involved in this very important meeting. The remit of my talk is active surveillance. And for the next 10 minutes or so, I will talk about the indications, the risks and benefits of active surveillance for localized renal masses. So let's start by, let's start by definitions. Active surveillance is described by the EAU, ASCO, and AUA as the monitoring of lesion behavior through serial imaging and delayed intervention if clinical progression is seen. I think it is important to note that active surveillance is different from watchful waiting. At least in our departmental practice, watchful waiting is delayed intervention when clinical symptoms actually arise. But the aim for both strategies, however, is to prevent or delay treatment-associated toxicity. So why offer active surveillance? And why is it an important management option? Well, for a start, CR UK statistics show that the peak rate of kidney cancer cases actually occur in the 9th decade, when there is likely to be competing medical problems and when a localized renal mass, especially a small renal mass, may not actually be clinically significant. There's also been an increase in diagnosis and almost double in numbers, in fact, since the 1990s. And this is likely due to an increase in the use of cross-sectional imaging, and almost half of all cases are diagnosed as stage 1. This study, published in a JU Roll a few years ago, illustrates that this increase in incidence is associated with an increase in robot-assisted partial nephrectomy as a treatment option. And this is the only treatment modality that has increased over the years, shown here on these bar charts on the right in red. Graph A is all comers. Graph B shows the treatment modalities in patients over 75 years of age. And graph C are patients with Charlson Comorbidity Index 2 or more. So it's a bit of a surprise that the proportion of ablation, which is in the purple, and active surveillance, which is right at the bottom in the blue, light blue, is not significantly higher in graph B or C. But I guess it's also data from 2010 to 2014, and it may be a very different set of graphs if more recent data is used, as I think these two treatment modalities have become a bit more mainstream and accepted. So why offer active surveillance? Well, for a start, a significant proportion of localized tumours are benign, especially the smaller ones, which are less than 4 centimetres, as seen here in the red boxes. And even those that are cancers, these tend to be of low grade, irrespective of histology. So even if it's clear cell, papillary or chromophobe, if they're less than 4 centimetres, it's more than likely they are going to be low grade. And who should be offered active surveillance? Well, various recommendations have been proposed by the main neurological associations, and these include the small renal mass, that is less than 4 centimetres in patients with comorbidities and or limited life expectancy. Going one step further, ASCO has recommended that those that are less than 1 centimetre, and the AUA has recommended those that are less than 2 centimetres should be offered active surveillance. I should also mention that these size indications need to be interpreted in context and should not be applied, for example, in patients with rare aggressive tumours or suspected rare aggressive tumours such as HLRCC, which has been known to metastasize at sub-centimetre sizes. ASCO also recommends active surveillance in those of high anaesthetic risk or at risk of end-stage renal disease. Our practice at the Specialist Centre for Kidney Cancer at the Royal Free is to also offer active surveillance for those with benign histology on renal tumour biopsy. And I think it is important to bear in mind that for patients that are deemed unsuitable for intervention, then perhaps watchful waiting should be discussed and considered rather than active surveillance. I guess the overriding question for clinicians and for patients is active surveillance safe? And to answer this question, I think it's important to note that this important study and other published studies show that not all cancers grow, and that benign lesions can also grow, and that if growth exists, this is not, it doesn't have to be linear. In fact, more than a third of lesions actually decrease or are stable in size, and only a third fulfill criteria for clinical progression. Having said that, growth can be a sign of high-grade kidney cancer, and high-grade RCC tends to grow faster, as shown here in this study published in the AAU. But I think the fear for both clinicians and patients in using active surveillance is the risk of metastases. And studies seem to show that this is a low event rate, especially in small renal masses, with approximately 1 to 2% progressing to metastatic disease. Analysis of SEER data suggests marginally reduced cancer-specific survival of around 2% compared to ablation or partial nephrectomy at 3, 5, and 9 years. And the 5-year analysis of the DISRIM registry certainly supports the notion that active surveillance is safe, though that's not statistically significant. I suspect that given the relative excellent prognosis of small renal masses, a direct randomized controlled trial using oncological endpoints is not going to be feasible in the foreseeable future. So what signs can be used as red flags in active surveillance? Well, ASCO have recommended that delayed intervention should be considered if the overall size of the tumour breaches 4 centimetres, or if there is more than 5 millimetre growth per year, and in the unfortunate and hopefully rare event that metastatic disease develops. And follow-up should be guided by the presence of symptoms, the Charlson Comorbidity Index, and local practices obviously differ. Our practice is a modified version of the one proposed by ASCO, in that we offer a scan at 6 and 12 months and then at yearly intervals. But this is again guided by growth kinetics and the individual patient's wishes. I'd like to finish the talk with this slide about quality of life, which I think is of utmost importance given the population that is most likely to be affected by this. And this is a report of a prospective study using the SF12 in graph A. Graph B shows the mental component summary, and graph C shows physical component summary results in patients in the DISRIM registry, with around 250 patients in each arm, ones which are undergoing primary intervention and those that are having active surveillance. And this showed that patients undergoing primary intervention had higher quality of life and physical component scores at baseline, which persisted throughout their follow-up. Average follow-up was 60 months. And what I think is most interesting, and the take-home message from me from this study, is that the mental health of patients, which includes the domains of depression and anxiety, and the graph B in the center, which is highlighted here, was not adversely affected while on an active surveillance regime. So in summary, I hope that I have shown you that active surveillance for localized renal cancer can be safe, it can be effective, and it can be used without adversely affecting the mental health of our patients. Thank you for your attention.